Good morning and welcome to all for the breast cancer session today. Most of you know well about breast cancer being working or associated with oncological patients. Breast cancer is the most common healthcare burden in our part of the world as well as in other countries. But when detected early, it's highly treatable, and survival risk improves when early diagnosis is made and these patients are cured. Today's discussion will revolve around the approach to challenges and effective ways of early breast cancer diagnosis and its prevention. It's my great honor to introduce our distinguished chair for today's event, Professor Kausar Bano. She's head of Department of Oncology at Jinnah Hospital, Lahore, where she has been a leading force in advancing cancer care. With her vast expertise and commitment to patient care and education, Professor Kausar Bano brings invaluable insight into this sessions of breast cancer early detection and prevention, and she'll going to introduce our speakers for today.
Thank you, Dr. Taira, for the intro. Now for the first talk of our session, I would like to, and we had the privilege to introduce Dr. Julie Gallo. She's a prominent leader in oncology and a passionate advocate for improving cancer care worldwide. As a chief medical officer of the American Cancer Society of Oncology and professor emeritus of medical oncology at the University of Washington School of Medicine, Dr. Grallo have unparalleled expertise in advancing cancer treatment and research. She is also the founder of DCAN, an initiative dedicated to supporting cancer advocacy in low and middle income countries. Yesterday, we had an informative session with her on global strategy for equitable cancer care. Today, she'll share her insights on breast cancer prevention in low resource setting and global breast cancer initiative, a way forward. So, with me, welcome Dr. Julie Grallo for her talk. Thank you.
Thank you very much to the conference chairs, to the sessions, moderators for the ability bit about and there we go. Is that better? Yep. A way forward. So I spent the first 30 years of my career as a breast medical oncologist at the University of Washington and Fred Hutchinson Cancer Research Center in Seattle. And now I call myself a recovering breast oncologist because for the past 4.5 years, I've been the chief medical officer at the American Society of Clinical Oncology, where I'm supposed to represent all cancer as opposed to just breast cancer specifically. These are statistics that you probably know well. They're from IARC, the International Agency on Research in Cancer, and this shows global patterns of breast cancer incidence in 185 countries. The darker the color, the higher the incidence. So the United States, Canada, Australia, and the darkest purple color have the highest incidence. Pakistan is in there in kind of a medium pink color. But then for mortality, we see it flips in many ways. And some of the countries with the highest incidence have lower mortality. So this just puts in perspective that although cancer is more common in higher income settings, the survival is superior. And this shows the what I've just said, essentially, the mortality to incidence ratio. If the Human Development Index in a country is very high, then the ratio of mortality to incidence is low. It's low risk of death per diagnosis. But if the Human Development Index level is low, then if you get a breast cancer, sadly, you have a much higher chance of dying of it. In 2022, which are really the most recent statistics for which we have solid confirmed data from IARC, there were 2.3 million new cases of breast cancer and 630,000 deaths from female breast cancer globally. The incidence of breast cancer has been increasing 1 to 5% annually in about half of the countries that they looked at. And the mortality rates have decreased in 29 of the 185 countries they looked at. But virtually all of that benefit, the gain in reducing mortality, were in countries with a high human development index. By 2050, it's projected that new cases will increase by almost 40%. And deaths are projected, sadly, to increase by almost 70%. And these rises in incidence and mortality are both expected to disproportionately impact low human development index level countries. So I looked at Pakistan in preparing for this talk just to see what kind of statistics you have. I know you don't have a national cancer registry, and so these are estimates based on your regional or hospital-based registries. But this shocked me because this is the incidence and mortality of the top 15 cancers in Pakistan for men and women combined. And look at breast cancer for men and women combined, the incidence is is huge. And lip and oral cavity comes next in terms of incidence, and we know that's pretty preventable. And mortality for breast cancer for men and women combined is the highest of the top 15 cancers in Pakistan. So breast cancer is a huge, huge problem for you. And then these are the predicted trends in breast cancer from IARC. If we take the 2022 data and project it out just over the next few years, we're projecting that, I'm sorry, this should say 2050, not 2025. The mortality and the incidence are both expected to more than double from 2022 to 2050 in your country. This is a report that I will point out to you, it was just released at the end of September. It's done by the Swedish Institute for Health Evaluation, and it was unveiled during the UN General Assembly Week during the high-level meeting on non-communicable diseases in New York. And this is called Bridging the Gap in Women's Cancer Care, a global policy report on disparities, innovations, and solutions. So this is available free online. I'd point you to it. What was very interesting when I saw this presented was it clearly, obviously, just makes the case for us that your survival is incredibly based on stage, and we should be focused on downstaging. If you're diagnosed with stage breast cancer, your 5-year survival is about 33%. But if you're diagnosed with stage 1, your 5-year survival, if you have access to diagnosis and treatment, is almost 100%. But then when we go and talk to our policymakers, it's the next figure that's really interesting, the cost of treatment based on stage. Look at that. So if the baseline is how much it costs to treat a stage 1, if we don't diagnose till stage 2, it costs 32% more. If we don't diagnose until stage 3, it costs almost 100% more, and even more than 100% more if we diagnose at stage 4. So if we're trying to make the case for having early diagnosis, we're also doing this not just to save lives, but also it costs a lot less. And in the same report, they looked at all women's cancer, so gynecologic and breast. I'll just pull out the breast. They looked at where are the best buys. So they looked at the prevention potential. And really, compared to cervical cancer, where we have a vaccine, they said the prevention potential of not having the breast cancer occur at all was on the low side compared to some of these other cancers. But detection and with screening it was available, and there were good early detection opportunities. For diagnosis, the potential for biomarker-driven personalized treatment was high. And for treatment, this is the number of EMA-approved medicines for breast cancer between 95 and 24. There were 57 new meds in that time period. So this is trying to look at, for cervical cancer, we should clearly be focused on prevention. Breast cancer may be more on the early detection arm. So we can think of prevention, or probably more accurately called risk reduction, because we can't prove to anybody that anything they do will 100% prevent, but we can reduce the risk, right? There's a little bit of a difference there to cancer. So for primary prevention of breast cancer, we know that some of the risk factors are lifestyle factors, a sedentary lifestyle, and weight. Chemo prevention drugs are available, although not widely used. But drugs like tamoxifen have been shown to somewhat reduce the risk of breast cancer in patients with higher risk. And then if a known gene mutation that's inherited, like a BRCA1 or 2 gene mutation, is found, then for that specific subpopulation, maybe even preventative prophylactic surgery could prevent the cancer from happening in the first place. But also under risk reduction, we talk about secondary prevention, which doesn't prevent the diagnosis, but it prevents the morbidity and the mortality of the cancer. So we call that secondary prevention. And that can be done with screening, which I know you don't have a national screening program, but we can do lots of things to get earlier detection without an organized population-based screening program. And again, this is just reviewing the major risk factors for breast cancer, but just to point out, increasing age and female gender are the two biggest risk factors for breast cancer. So we can't do a lot about that, and most of us probably don't want to do a lot about that. But hormonal reproductive factors, and many of these things we also can't do much about. So if we talk about prevention, you really can't change the age at which you go through menarche or menopause. We can change maybe the age at which we have our first child, but do we really want to make that decision entirely based on a small decrease in breast cancer? Probably not. Fewer children is associated with higher breast cancer risk. And if we take exogenous hormones, menopausal replacement hormones, we increase the risk maybe a little. Genetics, family history, really important for a minority of our patients. And then lifestyle, I've mentioned overweight, obesity, decreased physical activity, and a contribution of alcohol. So these are the kinds of things we can talk about with our patients if they say, what can I do to decrease my risk? But for the most part, being female and getting older are the two biggest risk factors. In the US, we developed what we call our National Cancer Institute Breast Cancer Risk Assessment Tool. This works very well for the general population. It does not work well with a strong family history, okay? But in this tool, you can access it online, but it is adjusted for a US white population. You put in the current age of the patient, the age at their first menstrual period, age at their first birth, the number of first-degree relatives with breast cancer, the number of prior breast biopsies they may have had, and there's a little adjustment for race within a US population. And then you get some numbers that can be helpful in talking to your patients. So just to give you an example, if you have a 35-year-old woman who comes into clinic and she's worried about her breast cancer risk, and you would enter the information into this tool, you'd say her first menses was at age 10. She hasn't had a pregnancy yet. She has 2 first-degree relatives with breast cancer, which is why she comes in to see you. She's very, very nervous. But according to this tool, her risk of developing breast cancer, because she's only 35 now, in the next 5 years is only 1.1%. But because of those risk factors, her lifetime risk is 1 in a third of getting breast cancer. So helping her sort out when she might want to start screening, et cetera, is very helpful. Now, in this patient, I would also advise with 2 first-degree relatives with breast cancer that she undergo BRCA testing to see if that might be influencing. And if she is negative, if we can identify a BRCA mutation in a family member and she's negative, that would bring her risk down to a lower level. But here's another patient who is 55 years old. She had her first menses a little later, which would reduce her risk. She had her first pregnancy fairly young at age 25. She only has one first-degree relative with breast cancer. She has had a prior breast biopsy. Her risk in the next 5 years is higher than that 35-year-old, 2.7%, but her lifetime risk is lower. It's only 18%. So this helps put in perspective for our patients. And I've seen that some other countries have adapted this to their own patient population. And this is, as I say, only validated in the US population, but this is something interesting as a tool to help when we're counseling women about their risk of breast cancer. So secondary prevention, I've told you, is not preventing the development of breast cancer, but preventing some of the morbidity and mortality by finding it earlier. And we know that early detection can be done without population-based screening in a country that's well-equipped, lots of mammographers, et cetera, and that you, if you find something, have the capacity to then do the diagnosis and then do the treatment. Screening might be reasonable. And in visiting Shaukat Khanum earlier, asking questions, that's not where you are, but we certainly can create awareness, have people, when they have a symptom, come in earlier, and that's one way of downstaging. But early detection, as I've indicated, is really, it doesn't do anything to start a screening program if you can't follow that with the diagnosis and the treatment. The WHO has put out, back almost more than 10 years ago, a position paper on early detection and screening mammography. And I put this in here just to say that they support early detection. And they say that early detection, early diagnosis, just based on awareness of signs and symptoms of cancer, and then taking action on them, is one strategy for early diagnosis. Screening, which would be systematic, population-based through mammography in an asymptomatic population, can also be used. But both are valuable tools and part of early detection. Now, I was asked to address the Global Breast Cancer Initiative. This is a WHO initiative that was launched a couple of years ago, and it has 3 pillars. Pillar 1 is all about the early detection, health promotion, and early diagnosis. And it sets a goal of achieving a diagnosis of stage 1 or 2 in at least 60% of your population. Pillar 2 is then timely access to diagnostics. The goal here in this pillar would be that evaluation, imaging, tissue sampling, and a definitive pathology diagnosis would be completed within 60 days from when the patient first presented into the system. Okay? And then pillar 3 is that you get the treatment. Comprehensive breast management. The goal here is that 80% of patients will undergo multimodality therapy when indicated, surgery, radiation, chemo, without abandonment. So they've completed the whole course of intended treatment and a successful return to the community. And they're aiming for 80%. So they call this 60-60-80. So you remember what your goals are. And the overall goal is, if we can achieve this, then we would like to be able to decrease breast cancer mortality by 2.5% per year, averting 2.5 million breast cancer deaths worldwide if we started in 2020 and go out to 2040. So this is a major WHO initiative. It goes along with the Eliminate Cervical Cancer campaign and the Childhood Cancer campaign of the WHO. And just to look at it a little differently, to kind of drill it in, you've got the early detection, which is the pre-diagnostic interval. You don't know you have cancer yet. And it will begin either from when the patient presents with a symptom, or if you're doing screening, from when you have that first abnormal screening image. And remember, that was 60% should be at stage 1 or 2. Then you've got the definitive diagnosis period, and that interval starts from when you find the abnormality, they first present with it, until you've got a pathology report that spells out, yes, this is breast cancer. And again, we want that to be within 60 days. And then the integrated care from the time of diagnosis, from the time of treatment initiation to the time of treatment completion. We want to know how many patients have completed everything that was intended across all disciplines, and that should be 80%. So as going back to that Swedish Institute for Health Metrics report that was just unveiled, they took a look to see who was meeting their goals, what countries were meeting their 60, 60, 80 goals. And this is just looking at the stage at diagnosis being 60% stage 1 and 2. And Pakistan doesn't show up in this list. I don't know if they've actually looked at it, but you can see the dotted line is that 60% are presenting at stage 1 or 2 or lower. And you can see some of the countries, the green means it's stage, the dark green is stage 1, light green is stage 2, and then the orange and red are stage 3 and 4. Some countries are doing really well. Bulgaria, Slovakia, South Korea. Some countries are well below that 60% goal. Uganda, Zimbabwe, Colombia, Iraq. So knowing where you are now and where you want to be in 2040 to meet these goals is really important. And I applaud your country for actually, I think just this year, having law actually looking at implementing a national cancer registry. So you know the incidence, the stage, and the mortality. And so why is all this late detection happening? You know this more than I do in your own country, but across the world, it's the fear of that word cancer and its consequences. There's an awareness and action disconnect. Many of the patients I meet around the world that present with a large fungating breast mass, they know they've had a breast lump for a long time, but they also don't know anybody who's ever gone to the cancer hospital and survived. So why would you go early when you're pretty asymptomatic? Why you would wait until you're having symptoms and you want help with the symptoms. Lack of organized screening programs, and then just low participation rates in any screening or early diagnosis programs. Also just unveiled recently, this was published just a couple of months ago, is a proposed breast cancer care quality index. And I won't go in the details of it, but some of you who specialize in breast cancer might want to look at this. There are 5 domains proposed for a site that's giving breast cancer quality care. That would include health equity, patient-centered care, universal health coverage. There's a healthcare quality with 6 domains: safe, effective, patient-centered, timely, efficient, and equitable care, and then treatment effectiveness. So some of you who are specialists in breast cancer might want to take a look at this publication. And going back again to, are we talking to our policymakers now about wanting to invest in breast cancer and early detection? Going back to the Swedish Institute for Health Economics report, is there an investment case for women's cancer? Well, in addition to saving lives and preventing orphans and keeping women in the workforce, et cetera, we have fewer disabilities and deaths, longer lives, more workforce participation, increased economic contributions to society, decreased dependency on social support. Economies are stronger overall because of all of this, and women can continue to contribute to society. So there is a case to be made that there is an investment case. Investing in the prevention, early detection, diagnosis, and treatment of women's cancer is not only a public health imperative focused on saving the patient's life, it's also an economic strategy. It can save the country money in the end. So in 2024, The Lancet issued a breast cancer commission, a roadmap to address breast cancer challenges. I just refer those of you with a special interest in breast cancer that haven't seen it to take a look. And they come up with 6 kind of buckets of recommendations on things that would help prevent or mitigate the modifiable risk factors, personalizing treatment, getting the right treatment at the right time for the right tumor and the right patient. Inclusion of metastatic breast cancer, this has been omitted in many countries, is that they're abandoned. They might get one treatment or anything, and then they're put on palliative care. And there are many effective therapies for metastatic breast cancer in this day and age. Tackling gaps and inequities through collaboration, identifying the hidden costs of breast cancer, which gets back to that, is there an economic case? But they did estimates of how many orphans are left behind every year in the world because of breast cancer death at an early age. And then communication and empowerment, put patients at the center of clinical communication, empower the patients to exercise their own voices about their care. In the United States, I go and I talk to our congressional representatives all the time, and I can come and say, as an oncologist, we suggest this. But if I bring a story about a patient that's a constituent of the politician, and I say, let me tell you a story about one of my patients who is in your voting district, right? And I'll give you that story. That resonates much, much more with them than me as an oncology expert telling them what they should do. And so as part of my hobby in my career in breast cancer and global health, years ago in the late 90s, I was doing a USAID project on breast cancer in Ukraine. And I met some patients at the time. It was not long after the fall of the Soviet Union, and the teaching had been, you don't tell a patient if they have a cancer diagnosis. This was just the Soviet teaching, because they will commit suicide. You know, you are giving them this diagnosis. And so patients, even in the late 90s in Ukraine, would be in cancer hospitals on a ward that says chemotherapy. And when they said, I have cancer, don't I? They would be told by their doctors and their nurses, no, you just have a very bad infection that might make us have to take off your breast. And then you might need a really potent antibiotic that might make you lose your hair. So that was my experience in the 90s. In Ukraine, there was no communication, but we found some patients who, of course, knew. They read the chemotherapy word sign. They wanted to talk about it. They wanted to have dialogue with their nurses and their doctors. And that was one of the parts of our project. And it started an advocacy movement in Ukraine, which in 3 years, we had permitting walking down Krushatik Street, the main street in Kyiv, of breast cancer patients saying, we're alive, we survived, we're doing this for our daughters. So with that, I said, I need to support you and help you develop, and I want it to spread to the region. We're supported, and this stuff came out after I started my weekend work empowering patient advocates. The US Institute of Medicine said in 2007 that cancer control opportunities in low and middle income countries, that patient advocacy has a key role to play in bringing the public's concerns about cancer to decision makers. And at the 2017 World Health Assembly, there was a cancer resolution, and one of the bullets of the cancer resolution said we should continue fostering partnerships between government and civil society, building on the contribution of health-related non-governmental organizations and patient organizations. So WHO is telling us we should be working with the patients. And I just put these 2 fun pictures, one from one of our weekend meetings, bringing together patient advocates from 12 countries in Eastern and Central Europe. This happened to be a Kiev advocacy conference, but we rotated through the region. And then because of my Cancer Institute's relationship with the Uganda Cancer Institute, we were invited into Eastern and Southern Africa to do the same thing with the patient advocates. And I am so proud of them. And they will go to Parliament and they will march in the streets, and they have made real strides, and they are terrific partners. And I'd encourage you to explore that and grow your relationships with the patient advocates in your country. So with all of that, Let's work together to achieve high quality and equitable cancer control and care for all. Thank you. You want to sit there? Okay.
Thank you, Dr. Grallo, for such an insightful and informative talk. And really, as Pakistani, we feel the need to have such strategies and policies for our patients so that we can have early detection of breast cancers. And you rightfully said that if we early detect and early treat these patients, our cost is going to be minimized as compared when we deal with patient with and cancer advocacy. As president-elect of the Union of International Cancer Control and founder of Medicine Cancer Foundation, Dr. Bogoda had played an important role in improving cancer care and awareness, particularly in Nigeria. Serving as senior advisor on women health and cancer advocacy to Nigeria's coordinating Minister of Health, she brings a wealth of experience in addressing the unique challenges of cancer care in resource-constrained settings. Today, she'll share her perspective on breast cancer awareness, drawing from her extensive work in Nigeria. She will be talking about breast cancer awareness, our perspective from Nigeria. So kindly join us for this informative talk.
Greetings. My apologies for not being able to join you in person. My name is Zainab Shinkafi Bagudu. I'm the CEO and founder of the Medicaid Cancer Foundation, a non-governmental that operates in northern Nigeria. I'm also the president-elect, a three-time board member of the Union for International Cancer Control, and I'm joining you in Lahore, Pakistan today to talk about breast cancer awareness and prevention from an LMIC perspective, and to share my experience as an advocate working through different platforms in Nigeria with you. The statistics are very clear. Cancer is a burden for LMICs. A Nigerian under the age of 75 has an 11% chance of developing any type of cancer in his or her lifetime. The most common cancer is breast cancer, and it affects women under the age of 40. If we look at the African continent generally, breast cancer accounts for 25% of all female cancers. Late presentation is the norm. Most 70% of cases present in late stages, that is stage 3 and stage 4. Late presentation makes the disease more complex, it makes it expensive, and of course, treatment is less successful, resulting in death. According to the statistics, Nigeria reports over 28,000 new cases every year of breast cancer, and over half result in death. We know that these figures are underreported due to weak health systems. We have different barriers that cause all these figures that I have mentioned. There are limited screening facilities, human capacity is poor, is low, and human resource is not adequate for the size of our country. In addition, we're seeing a lot of professional flights where the healthcare workers are leaving for higher income countries. Treatment cost is high. We don't have any chemotherapeutic agents manufactured locally. And then, of course, the big one, even though it might not sound as serious, is cultural beliefs as well as stigma. This hinders a lot of the work that we do, and sometimes we have to make active efforts to address these figures first of all. So the government is making its own efforts through different policies. We now have a National Cancer Control Plan. We have a National Institute for Cancer Research and Treatment, they're working hard to strengthen the cancer registries in collaboration with partners from IAC. Radiotherapeutic access is being expanded to the tertiary institutions, 2 new centers were recently commissioned, and I believe that they have started to see patients. We can have the facilities, but maintaining them is key. And then also, who is going to afford it? For this reason, the National Health Insurance Scheme has been brought into the non-communicable disease space. It's expensive for them, but it's working. We also have other partnerships with farmers that enables patients access chemotherapeutic agents and pay maybe about 30% of the costs. So these are the efforts that government makes, and the policies are there. It's not always perfect. At least we have the efforts and the steps are being taken. As an advocate, we work through different platforms. The two that affect cancer, as the CEO of the Medicaid Cancer Foundation, and then also through the First Ladies Against Cancer. In particular, I will speak about the Patient Access to Cancer Care Evolution PACE program that we run at the Medicaid Cancer Foundation. It was launched in 2019, and it is to break the barrier costs. We do it to support patients through collaboration with pharma and fundraising so that patients can access care at a lower rate. It helps patients reduce the cost of chemo by up to 54%, and we've seen an 80% increase in patient in treatment initiation with the PACE program. So it's a good program and one that I encourage other people to emulate. Community impact is very important for us at the foundation, and we engage in nationwide screening, not nationwide in that it's state by state, modular. So for the FLAG First Ladies, each First Lady can organize screenings in her state, targeting markets, schools, rural areas, and creates that much needed awareness. Ditto for fundraising, subsidized treatment, partnering with community gatekeepers, the leaders, the community, the religious leaders, the traditional rulers, very important in the African context. And they act as voices that help us to spread our messages and unpack the stigma and myths and misinformation that is so rampant in the health and cancer space. Capacity building is an issue, and we are seeing professionals who are not as happy with the training conditions. So we help them by providing these classes that they can, training sessions, workshops in cervical cancer, pap smear, breast examination, especially for the community health extension workers. And this is very morale boosting and enables us to detect cancer earlier. There are 5 non-negotiable strategies, some of which I've mentioned, but I'll just go through them again briefly, that we engage in, and other LMICs have to also put into their work. Your work is only relevant if the people at the grassroots are listening and can hear it. So community-based strategies using the local language, survivor stories, amplifying them is very important. Because of the myths and misinformations that we have, we need to show that, yes, cancer exists, but yes, you can survive by using these treatments. And here are some people that have done so. The Walk Away Cancer is a very popular walk that we have at the foundation that happens every October. And we try to do all these things, reaching into the community, bringing high impact influencers to send the messages and create that awareness around the events. Primary care empowerment, training the midwives, nurses, community workers, as well as even doctors in early detection and referral. Mobile screening units is an area where we would like to expand into, but not just for mammography, but also for using ultrasound. Ultrasound is more achievable, and we have what we call the FLAC clinics in collaboration with Roche, where each flag state has a clinic, and this carries out the basics of screening using breast cancer screening using the ultrasound, and anything picked up is referred to the secondary unit at the hospital. Working together to raise funds, partnerships for financial access, as well as data. This is an area where we haven't done so well in generally, but we do try to capture what we're doing and have very clean data so that we can show and encourage people and other organizations to support us, especially the government. So I would like to go over a few steps and strategic actions that will help us to reduce the burden of breast cancer. Awareness and education using media is number one. Targeting workplaces and community groups. Women groups are very popular in the African continent, and we can use these groups using the voices that they trust to send the messagings around breast cancer. As a member of the Africa Breast Cancer Council, we do a lot of policy engagement, and this is also part of the work that advocates need to work, engage in. Policy can be from expanding to the health insurance or creating access programs that enables the cancer patients to survive and thrive. Screening also, because our health systems are weak, there are lots of credible non-governmental bodies doing screening about in pockets, but that has to be captured better. And until then, we'll just keep on doing it, and we don't have the data to actually show how many patients we screen altogether in the country as civil society. I know that some people have made efforts, but this hasn't been very successful. And training our general practitioners, we have an increasingly high number of family physicians who can be used to be the first point of call for breast cancer. We can't do all this without partnerships within ourselves, with governments, with funders, with different bodies is the only way that we can continue to do the work that we're doing. So my call to action is simple. The fight against cancer is not one that one person or one organization can do. If we're really serious about saving lives, then we must realize that it's about restoring the dignity and dismantling inequity. A woman's survival should not depend on her postcode or her pocket size. Partnerships are key, and every life that we save is a victory. Every barrier we remove is progress, and every partnership that we forge together brings us closer to a future where breast cancer is not thought of as a death sentence. So these are the key things that I want us to take away in my call to action. Partnerships, bringing together different parts of the cancer spectrum and those who are involved, and realizing that our goal is to detect breast cancer earlier so that we can save more lives. I thank you very much for listening.
Dr. Zainab's lecture was quite eye-opening for all of us, and it tells us that in a resource-limited country like ours, we can, with the collaborative efforts of all the stakeholders from who are related to health care, can improve the outcome of breast cancer patients and help them for the early detection and treatment of these patients. So now we are here with our last talk of the session, and we have Dr. Lubna Mushtaq Vora with us. Dr. Lubna is a highly accomplished breast surgeon. She is currently working, serving as a section head of breast surgery and associate professor in the Department of Surgery at the Aga Khan University Hospital, Karachi. She holds fellowship in oncoplastic surgery from Germany and breast surgery from Aga Khan University. In addition, she is also fellow of American College of Surgeons. She is a European and the member of European Board of Surgery. She is also fellow of the College of Physicians and Surgeons of Pakistan. Dr. Lubna is widely recognized for her expertise in breast cancer surgery and her commitment to advancing surgical education and women's health. We are privileged to have her share her insights with us today. She will be talking about advancements and challenges in early detection and surgical treatment in Pakistan, impact on patient outcomes. So please, Dr. Lubna.
Assalamu alaikum and good morning. Thank you very much, Kausar, for such a wonderful introduction. Thank you, the organizing committee, for inviting me over here. As we heard about the global perspective of breast cancer, and then from Nigeria, Zainab told about the LMIC perspective. Now we are going to have our own perspective, Pakistan's perspective, our own touch. So what we are facing, what are the challenges, and how we are planning to move forward. That's my disclosure slide, no conflict of interest. This is going to be the objective. I'm going to discuss first the challenges we are facing as a breast surgeon or as an oncologist, maybe, while dealing with the breast cancers, and what advancements we made in this country and how they're impacting the quality of life of our population who are suffering from breast cancer. So just a little review about our own epidemiology. This is the National Cancer Registry report published in 2023. And this is the reported data from different institutes, Atomic Energy, Shaukat Khanum from Al Khan University, and few of the institutes from Punjab. This is not a nationwide cancer registry report, it's just a report of what is reported by that centers. So yes, you can see here, breast cancer is the most common cancer among both genders combined. And when we see is a commonest cancer in female. But what are the challenges as a LMIC? The challenge is that we are a lot of lower middle. I call myself a low income country citizen, where the total allocation of budget for health is much, much less than what WHO is recommending. It's only 3%. So this is the biggest challenge for this country when we talk about early detection or screening or diagnosing or treating breast cancer patients. This is an AI generated image, which I asked AI, I write some, the keywords, and I ask from my perspective, what are the challenges in my country when we talk about early detection and screening and the impact? You can see in that image, a woman is scared, stage 4 is a high burden disease, and then they don't want to go to, obviously, to the male doctors. So now we are going to discuss with screening. I called it is an opportunistic screening because we don't have national screening program, not only for breast cancer, but not for all other cancers also. When we talk about colorectal or maybe for cervical also, we do not have a screening program. So most of the screening which we are doing in this country is an opportunistic screening. It means those who have access, those who have knowledge, those who have financials with them, they can go to screening facility and they can screen themselves for breast cancer, or maybe for early changes which can develop breast cancer in future. So when we talk about this country particularly, we talk about that most of our population is living in small villages and towns. Only 30% of the population is in cities. And those who are in cities, maybe they don't have awareness about screening. Those who have awareness, they have reluctance to get screened because they thought probably screening is going to overdiagnose them, maybe is going to overtreat them, maybe the number of recalls, maybe the burden of diagnosing the disease, or there are myths which are associated with the screening. It means you have patients, you encounter patients that talk about why screening. I believe this regular screening is going to develop a breast cancer in my breast. So this is the strongest myth in this country, that screening can cause breast cancer. And screening mammogram can develop breast cancer, and that's why people are looking for alternatives. Even when we talk about breast self-examination, sure. So in the sense of breast self-examination also, people don't examine their breast regularly. Even our literate, educated women, when we ask them when you discovered this breast lump, and they then come up maybe yesterday, maybe a week ago. So that's how the screening is in this country. Now, the other challenge we are facing is we have more and more young patients. When we compare our data to the global data, maybe to the US database or the European database, we have more and more younger patients. And our own demographic trends are showing that we are going to deal with more and more younger patients in future. The other challenge we are facing is obviously we do not have a screening guidelines in this country, as they have not a screening program. So we don't know what is the right age for this population to screen for a breast cancer. When we talk about young patients, obviously when you take a cutoff of 40, they don't fall in that cutoff. So when they discover a lump, they really don't know what is happening. And most of the time they are reluctant to seek advice, or maybe they are delaying to seek advice because they think that this is not an age of breast cancer. So might be I am harboring a benign lump. So what is the outcome? Bigger tumor sizes at presentation. Our own data from Pakistan is showing when we research publications, both indexed and non-indexed publications, you'll find that reported data is showing that 50 to 89% of population who are presented to cancer centers have advanced presentation. It means maybe stage 2B onward, maybe stage 3. So now you can see that how much is the burden of advanced disease in our country. And the reason is that we do not have early detection programs, or we do not have that much awareness about it. In this particular paper, which was published from our Khan University, and they have interviewed 500 individuals, and they found that almost 59% were at advanced stage. And most of the people who were interviewed, they said that they were harboring this lump or this lesion with a median or the medium period of 15 months. It means for almost 1.5 years, a lady is having a lump in her breast and she is just ignoring it because of many reasons. Uh, Another paper published recently from our Khan University, and we particularly targeted only young population, those who are in the age of 40. And you can see over here, the mean age of diagnosis in that particular population was 34.5, means almost 35 years. This is the age group where most of the women are probably busy with the childbearing or with their careers or maybe with their financial support system. So most of the time they are reluctant to seek medical advice, and that's resulting in an advanced stage at presentation. So what are the factors? This is a very good paper published from our own country, and they talk about the fear and barriers. First of all, we'll talk about lack of awareness. Yes, despite of efforts we are putting in, there's still a lack of awareness because women, they don't like to discuss their breast or this organ in front of others. In our part of the world, this is a stigma to discuss breast. They take it as a feminine organ. They don't want to discuss with male practitioners, maybe male paramedical staffs, maybe with their own family members. They don't know how to examine their breast properly. People do not have awareness about screening, that maybe the screening facilities would available in their own area, but they have no idea about it. And this lack of awareness at multiple fronts is causing delayed presentation at advanced stage, which is indirectly resulting in increased mortality associated with the breast cancer and also with the morbidity of treatment. The other factors which is well studied in our population is the spiritual healing. We have a very strong belief or sort of a misbelief. Spiritual healing is our strength. And in this part of the world, we as a religious people think that probably I called it spiritual spells, dam durud in the right word. Most of the time when people discovered this type of lesions, they really want to go first to the spiritual healers to seek advice. And they are with them for months and months and years and years. And when it comes to an end of advanced disease, they come to a clinician or a practitioner who is trained to diagnose and treat. So this is another factor which is delaying the treatment. And it is also because of our misconceptions and misbeliefs. Then the other problem in our part of the world is breast cancer is a taboo, is a stigma in our society. I'll talk about the entire country, Pakistan. All provinces, whether you're living in a cities or living in a towns or villages, it's still a stigma and a taboo. And women doesn't want to seek, social support. They don't want to discuss their problems in their breast, either with the family members or with the siblings. And they thought that if they're going to seek a social support, probably they're going to sympathize them, they're going to undervalue them, maybe they're going to curse them, because still in we think that cancer is a curse, is a punishment. A woman have done something wrong in life, and that's why she developed a breast cancer. As I said before, the feminine sensitivity is a sexual organ, and despite of sessions, awareness talk, and not to, we are trying to normalize this talk and talking about cancers, talking about breast. Women doesn't want to discuss their breast problems with anybody. Even they don't want to discuss breast pain with their family members, and they delay the seeking advice and treatment. You can see over here, one of the patient has she said that I didn't discuss with my husband for 6 months because I was confused. This is a very normal story in our setup. Then women come to us, they discuss, please do not disclose this diagnosis in front of my family members, in front of my husband, maybe use an abbreviated terminology, don't use a word cancer, because they thought that maybe they can divorce them or maybe they can go for another woman. So that's why they are delaying to seek medical advice. Then we do not have that many female doctors available. I would say a breast surgeons, a oncologist, or maybe a general practitioner. We do not have a countrywide, very strong family medicine program or a family practitioners where patients can go and get their breast examined. So obviously, because of our religious and cultural beliefs, women doesn't want to go to the male doctors. They don't want to disclose their breast in front of them. They don't want to disclose their history, and they really neglect that examination part. Now let's come to the infrastructure in our country. Yes, as I said, we are a low income country with a very low, a minimum health budget allocated to health. And obviously, cancer is a ignorant part of the healthcare budget. So the lack of financial resources is also a biggest reason. As I said, we have more and more young people who are coming up with breast cancer, or a middle-aged population of 40, 48, 50, where they are planning to build a new house, maybe. They are planning their kids to go to abroad for further education, or maybe their weddings. And that's why they really don't want to utilize that budget or that savings for their treatment, and that's delayed the diagnosis. Now come to the health infrastructure. When we talk about the health infrastructure, obviously, countrywide, if we talk about Balochistan, if we talk about maybe the faraway areas of KPK or AJK, or even in Sindh, or even in Punjab, you do not have a standardized healthcare infrastructure where a girl, a woman can go and seek an advice. And they have to travel for hours and hours. You have patients, I'm sure you all must have encountered patients who travel for 13 to 14 hours from one part of Pakistan to other part of Pakistan just to seek a standardized diagnosis or a cancer care. And this is not easy for them, obviously. So you don't have trained radiologists, you don't have trained staff, then you have reporting errors are there. Sometimes there's a big lesion seen on a mammogram and that was inadequately reported as normal. And as I said, screening facilities are limited. So what advancements we have made, and are we providing that advancement to each and everyone, or still we have access problems? So this is a recently published paper from Gilgit-Baltistan, and one of the volunteer came from US, and she started this program. They were there with the help of NGOs, and she talked about that local health initiatives can be taken, a plan can be developed for free breast examinations and mammographic services. Awareness campaign, I'm sure we are doing a lot of awareness campaign since last decade, and they are obviously doing good and raising awareness to some extent. I would not say that might be we are up to the benchmark. No, we are not. But still, we are making our effort. It's important that mobile screening units will be available for more and more for far-flung areas of Pakistan, especially town and villages, where they can go and provide mobile screening services. Then this is a very untouched area which needs to be addressed now, because with the help of artificial intelligence, you can develop uh, maybe apps, a mobile app, because everybody is carrying Android phone, and which is also available in rural areas of this country. So if you can develop a mobile app, a person can easily, calculate the risk, or maybe calculate with the help of questionnaire that she or he is carrying a problem, and then they can consult a doctor. So this is an unaddressed area still. I mentioned about Tashkhis. Tashkhis is a artificial intelligence created mobile app, which is not available right now countrywide. Is in the research portfolio, and which can help in early detection of breast cancer in our country. When we talk about advancement, yes, most of the part of this country, I'm talking about particularly about cities, have advanced digital mammogram machines. They have MRI, they have contrast enhanced mammograms in a specialized centers, and people can have a earlier diagnosis. And we know that in terms of diagnostic biopsy, the core biopsy is now the standard of care, and core biopsy needle is available all over the country. It's just a matter of seeking the right medical help. Then come to the advancement in surgical treatment. Yes, we know that breast conservation improves the quality of life. We have facilities for reconstructions. We have facilities of sentinel node biopsy to reduce the morbidity of cancer treatment. But in terms of access, are we providing the standard of care to each and every patient of ours in the entire country is a big question. So when you come to the breast conservation, the reported data from this country definitely showing that oncoplastic breast conservations or the breast conservations is a benchmark now. And more and more young surgeons are coming up. They are trained in these surgeries. And I'm sure in the last couple of years, because of this junior, or I would say young blood, is going to bring a change in this country, and mastectomy rate will be reduced, inshallah ta'ala. So, but there's a big but in our cancer treatment. Again, that we have published this paper, and we found that still the mastectomy is on high. Still, because of the advanced presentation, modified radical mastectomy is the commonest procedure we performed. And it's just because early detection strategies and the screening is not that powerful. So particularly in this country, why we have a high mastectomy rate? Because we have more advanced stage of presentation. We have limited access to radiotherapy, because when women seek advice, just because in their local area they don't have radiotherapy services, and the procedures, even for early breast cancer, T2 lesions, they proposed is go ahead with the mastectomy because you don't require radiation afterward. Obviously, if surgeon is not trained in breast conservation, or maybe he or she preferred to perform a mastectomy, that's the biggest reason. Radiotherapy is an additional cost, and that's why to reduce the cost of treatment, people opt for mastectomy. Yes, we do not have proper, techniques available for localizations all over the country. If you're doing neoadjuvant chemotherapy, or if we are detecting a very small lesions, we do not have facilities to perform localizations. And that's why mastectomy is the right answer. And now, the last but not the least, we have METs. If we perform a mastectomy, is going to cure the disease with zero recurrence rate. That's how we think about the treatment. So in the last, this is a big question you all should ask yourself whenever you're treating a breast cancer patient. Yes, we know because of improved adjuvant treatment modalities, targeted agents, improved chemotherapeutic things, we have a more and more better overall survival. But as a surgeon, I myself always ask this question: what will be the consequence of this surgical treatment on my patient? If this is going to affect her negatively in the psychology and in the mental health, I would consider doing something different. So the quality of life should be the utmost important thing whenever you are treating your patients. And if you're not thinking about their quality of life, then you are not doing the desired job. So I would conclude the way forward we have in this country is to expand the screening program to rural areas as much as possible, normalize the breast health conservations, try to subsidize treatment, and promote research as much as possible. For my young people, I encourage report your data. This is very important. We have a very few reported data from this part of the world. Until and unless if you're not reporting it, you're not reporting your patients, your outcomes, you're not going to improve over years. So I finally really want to acknowledge my patients who are a part of a survivor group, and they're always available to counsel those who are diagnosed or in the phase of diagnosis and who are anxious and who really want to deny treatment or to go for an alternative treatment. They're always available to help them out. Thank you very much. So I conclude on we must build a system where no woman is punished for being poor, rural, or unaware, because cancer doesn't discriminate, but access to care does.
Now we'll open the session for panel discussions and we'll happy to take any questions. Dr. Zainab will be present online with us for the session.
If anyone have any questions?
There are few questions online we have received with online audience. This one question, I think from it's best if we can have answer with from Dr. Julie. Any role of preventive vaccines in breast cancer? Where are we development is preventive vaccines for breast cancers?
What's the question? Are there vaccines?
Any role of preventive vaccines in breast cancer?
So for breast cancer, we don't have any known viral etiology, so we don't have any vaccines. There are very, very early stage clinical trials looking at can we create a vaccine to certain molecules that might be found on the surface, like HER2, for example. But it's not against infectious etiology, it's against markers. And they are very early stage, and we have not proven that they have benefit yet. So no vaccination to promote for breast cancer.
Good afternoon. Amina Khan from Shaukat Khanum Hospital. It was excellent discussions, excellent presentations, and a lot of eye-opening things that I was able to learn about different parts of the world. Thank you all for being here. My only question was that I've been working at Shaukat Khanum now for a few years, and we did this little project about screening at Shaukat Khanum. We live in a reasonably affluent, our hospital is in a reasonably affluent part of the city. And we offered women in our neighborhood to come for free screening mammography. We handed out coupons at home so that people didn't even have to worry about how they got to the hospital. And the distance from that neighborhood to us was very, very short. And it was actually dismal that despite having the imaging unit right in their neighborhood, having a free access to screening mammography, of all the coupons and all the assessments that we had made, we received less than 5% people who came for screening mammograms. So I really, really agree with Lubna in the sense that I think a lot of work has to be done on education, because that was an eye-opener for me also. The problem wasn't distance traveled, the problem wasn't access, the problem wasn't that the facilities weren't available, but the resistance to find out, the scare of having something to deal with was really big. And I just sort of wanted to have all of your opinion on one of you to see how, despite all the education that we're trying to do at a mass level, how can that be breached? How do we break through that psyche of women to have them come in? Because till the patient comes to us, there's nothing that we can do. So I think that's probably the biggest hurdle that we're facing internationally, maybe, but more so nationally. So what are your thoughts on that?
So I agree, Dr. Amna. It's very common that despite of education, despite of financial access, despite of literacy, I called education and literacy in a different sense. because most of the people are educated, but they are not literate. So even when they are literate, they denied screening. There are strong myths associated with the screening program in our part of the world, because they think they're going to overdiagnose us, they're going to subject us to the unnecessary biopsies, and maybe if something discovered, we have to engage with that treatment. So these are the very strong myths which are associated with our population. But I personally believe we should, talk more and more about screening. Usually what happened in our part of the world, usually in the month of October, we are doing a lot of awareness campaigns and, sessions and talks and talking about screening and awareness things. But in the entire year, we all are comfortably quiet about it. So probably the message is not as strong passing to them continuously. Maybe with some time, we can normalize this screening thing also. Even screening in that sense, I mean, they have to come and they have to get a mammogram done. Even people are not performing their breast self-examination regularly, despite of the fact you are telling them you have patients who are coming only for the screening purpose, and every time you ask, have you discovered something in your breast, and the answer is no, I didn't examine in the last 2 years. So that's how they are. Even a big fungating mass which we are encountering in our setup. I know Shaukat Khanum work in a different sort of a strategy, but in our part of the world, we're still seeing fungating tumors. And the simple question asked, when you discovered this lump, and the answer is 15 days ago. It's really impossible. So I think talking more and more about it, and raising slogans, and obviously at the level of policymaker, this is an important task they should take up as a project, uh, to normalize screening for all cancers in this part of the world, not only for breast.
Thank you.
Assalamu alaikum. This is Mohammad Mohsin from Shaukat, Lahore. My question is from Dr. Jolie. Madam, as you mentioned that in 2050 we are predicting about 68% mortality with the advancement in medical sciences. Why we are predicting so much high mortality in upcoming time?
I'm having trouble hearing. He's talking about high mortality. So I want to make sure I understand the question. You're asking about high mortality here in Pakistan?
Well, Madam, as you mentioned in your lecture that in 2050 we are predicting about 68% mortality. So my question is, as we are going in advancement with the passage of time, we are going to advance in the medical science. Why we are predicting high mortality?
Basically, it was like that the WHO initiative, with WHO initiative, there is a objective that the mortality rate per year to be reduced by 2.5%. In Pakistan, we are just talking that the incidence is high, there are late detections. So it's expected that if we do not follow these guidelines for early detection, then the mortality can be high by 2050. But with the WHO in global initiative, its aim is to decrease the mortality if the policy is made according to the WHO initiative.
Thank you.
Dr. Huma Majid, I'm a breast surgeon from Lahore. Two comments, very nice talk, something that we really need to do in this country on a national level, and it's lacking. One thing is that we have a higher incidence, I think. I don't have the actual proof, but we intermarry a lot. There is a lot of like first cousin marriages, family marriages, extended marriages, which can probably add, and the younger women that are being affected maybe because of that. The other thing, like you guys are saying about like even when they have the awareness and all that, why don't they come forward if they have access to? So women in this room are maybe all like less than 5% of Pakistani women. Women in this part of the world, they are not sort of trained to make their own decisions. So if you're socioeconomically dependent and you come from a culture where your father, your brother, your son, or your husband will make a decision, women become very indecisive. They don't know. They're not confident enough to come forward. So maybe
we need to involve men on a massive scale for screening purposes and for educational purposes. Awareness sessions for men exclusively should be inculcated. We go and we talk to women, but then, who's going to bring them? So that's
And I
my
think
just-
you had a picture in one of your slides that said something like "Stand by her," and it was a
Yeah,
man and a
yeah.
woman
For the
together,
screening program, stand by her side.
stand by her side.
Yeah.
I also saw I've seen a lot of interesting models, and it all has to be adapted to the culture and the context. But in Madagascar, a screening program arose around Mother's Day. And in the schools, there was general health education, and the children would write cards, "Mom, I love you. Please check out your health. Check out your, your breasts," and I thought that was a very clever campaign too, to involve the children and say, "We want you around." You know.
Thank you so much for very insightful talks from all the speakers today. I think, as Dr. Lubna has mentioned, that we only focus the awareness in October. So I completely agree that we have to segregate our, awareness program across the year. And I feel that we have opportunity, as you mentioned, that, we have to detect this early. So you could see the numbers in years of 40 years among women. I feel that we need to, divert this awareness program to the schools, maybe, when we have younger women with early menarche and they're developing breast tissues, this is the right time to educate them. So, from the public health perspective, maybe we need to take our awareness campaigns to the school. It may also help. This was the only reflection that while I was listening to you all. My question is, and now I'm going to be inadequate for the men. So I particularly would like to know from Dr. Julie that you talked about that this is also common or coming common among men. So right now in Pakistan, we know that we are not paying attention to this, area. So I would like to know how men are coming with these issues, breast cancer, to your services. And so we have a lot of stigma, even if breast cancer is among women. So how do you see this among men in high income countries? Thank you.
So male breast cancer obviously is small. It's 1 to 2% of breast cancer, but it exists, and most men don't have any idea that they have any risk. And as you say, there's even more stigma to be a male with breast cancer. We do have some male breast cancer survivors that are willing to speak out. So once a man has been diagnosed, we have groups and people we can refer to. I think so having a BRCA1 or BRCA2 gene mutation leads to a much higher risk of male breast cancer. That's not the entire cause of it, but that is a population we can target if we find a BRCA or a BRCA1 or 2 gene mutation in a woman. We talk about the whole family and the male risk, and we get at it that way too. So that's one strategy. We've had a couple of male actors who have had breast cancer who have been willing to speak out about it. And I think that helps some with the stigma, especially if they're an action star and they're willing to talk about it. So there are different strategies. But again, I think since 98+% of breast cancers in women, if we're going to focus a lot of energy, we should focus on the women, and also then have a way to support the men who are diagnosed.
So I just want to add few things when we talk about this, screening and male breast cancer and another portfolio. There was a study published recently from our Khan University, and we actually evaluated how many of our women population are affected with genetic mutations having breast cancer. So the reported data is showing we are on the higher side of whatever is reported worldwide. 22% of the women were harboring genetic mutations when were discovered with breast cancer. And they were young population. So obviously our population is probably different from whatever we are getting from the global perspective from the high income countries. Our data is matching more and more with, with the India and Bangladesh. Their reporting data and our reported data are matching because probably we are the same bloodline, harboring same genes most likely. And as Dr. Huma Majid mentioned about this, the marriages concept, you will agree to it when you are taking a very extended history with your patients and you found that many of their family members are affected by different sort of cancers. It's just because in most part of this country, genetic testing facilities are not available, or maybe a counselor is not available, and that's why there's a reluctance to undergo a genetic test. When we talk about this BRCA thing, when we discovered female having BRCA mutation, we asked for a cascade testing for the family members. And when it comes to the cascade testing, you won't believe the family members are reluctant to get themselves tested because even the male family members, brothers, or maybe the cousins, they don't want to get them tested because they think they're going to discover something new in my body and is now I have to go through the entire cycle of screening for years and years. So that's how somehow we are reluctant to accept this phenomena of screening and in the entire population.
Assalamu alaikum. This is Fatma Amin Khan from Shifa International Islamabad. Very nice to hearing your session. So basically, my question is related to my own family member. One of my cousin's wife recently developed a breast lump, and she was considering like for her diagnostic that it could be a breast cancer. So related to her mind, the question arises in my mind now, listening to your session, that she hasn't um, done any conceivement yet, and she hasn't have any babies yet. So she was like reluctant to be go to the doctor, that how does the breast cancer treatment affect the fertility in the woman. So I think being present at the back areas, as I belong from the KPK, Pakistan. So here are the very norms associated to the treatments. So this is the question that arises in my mind, that how to overcome that fears, and how much certainty in this thing.
And that was something I asked yesterday, and I can't remember who I had the conversation with, but it doesn't sound like fertility services are available in this country at this time. And that is a big deal to all these young women who are going through treatment. But of course, knowing what each sort of treatment does to your fertility, if you find it very early, then maybe you can avoid chemotherapy, which is the main culprit in reducing your fertility risk. And even the younger you are, the more, even if you get full-blown anthracycline-based chemotherapy, the younger you are, the more likely you are to get your menstrual periods back. So I think we have to individualize discussion about fertility. I can't tell you as a country when you should bring in fertility services, but we have them in the United States, and they're not always covered by insurance, but they're covered by some nonprofits. And it is something that really helps, especially in the young woman who hasn't had a chance yet to have her family think it through. So you have to figure out where on all of your asks that you want in terms of what's covered is when you're going to put fertility services in.
So basically, yes, I agree. We do not have countrywide fertility preservation services available with us, but there are alternatives. Like if I'll talk about Karachi, we have a hospital where we can have a service for ovum freezing or embryo freezing services. It's very expensive because of the cost. Most of the patients are not acquiring their services. But the most easiest thing we are offering when we are treating patients who are young, unmarried, or maybe they have not completed their families, is GNH-RH analogs. And that analogs can do ovarian suppression during chemotherapy, and that can be used to some extent, they can provide you fertility preservation. But yes, I agree. Most of the time when patients are seeking medical advice, especially for the sake of chemotherapy, this should be discussed, which people are not discussing with them. Even at that point in time, they are so anxious, the patient's so anxious about it, they do not have any idea how these chemotherapeutic agents are going to affect their fertility or ovarian function afterward. And most of the time, they're so naive, they come up with a question after completion of treatment that why I don't have my regular cycles, what happened to me? Or maybe I'm trying to conceive and it's not helping. So I think this is a time we should talk about it, and oncologists should take it forward, a breast surgeon should take it forward. At the time of diagnosis, this should be discussed.
Adding to this question, fertility is very important issue in our part of the world, and we know although we have a very large population, still fertility is the key issue. Every woman, even I have patients who have already 2, 3 kids, and still they're asking, can I have another child after this treatment? So as healthcare professionals, we need to counsel these patients that the main thing is patient herself. The fertility comes after that. Although it's a major issue if patient comes early and she is going to live a good will have cure and will have a normal life, she would definitely like to have kids. But still, there is a point because at times all the family comes and their main concern is not the patient treatment, but the fertility of that girl. So we need to put some sense into them that the primary concern of ours is the patient, not the one who has not arrived yet.
So,
Okay, here.
Mike.
Dr. Zainab, you can ask your question now.
Sorry, it wasn't actually a question. Good morning, everyone. I wanted to make little additions to some of the issues that have been discussed. Apologies, I can't have my video on. It's shaky, and then also I literally just got out of bed. Yesterday was our biggest fundraiser, which I spoke about, the Walk Away Cancer, and it was a huge success. It's these kind of campaigns that get people aware and more open about cancer generally. One of the things that we did that was very successful was to have a male breast cancer all through the campaign, highlighting the fact that men can get breast cancer too, and to draw the attention of men. Because it's in October, you tend to have breast cancer awareness events, whatever you're doing, mainly attended by women. And so I think that having more male advocates, more male patient advocates that have had the experience is very helpful. In another perspective, when my husband was governor of the state maybe he left about 2 years ago, and I was the first lady, there was a lot of resistance in our communities and our environments. It's a very patriarchal society, and men are the decision makers for everything. And so however, when we run, usually you have resistance to women attending screening clinics or any clinic whatsoever, even in the mid to higher income families. But when we organized a prostate program for men solely in the state, and there was a statewide campaign on prostate cancer and men coming out, and we found that a lot of men are actually very keen to talk about it, amongst other issues that they have around the waterworks. But that wasn't the issue. After that, the reception to the breast screening and breast awareness or women's health programs was much better, because the family heads of families have been able to come out and see that we're not really doing anything that is wrong or un-Islamic, and we were able to get their permission and support in getting more women to our clinics. And one thing I want to mention lastly is the issue of funding. I have seen a study that says 90% of funding for cancer, either you're talking globally, partners, INGOs, or national budgets, goes towards research. In LMICs, the funding goes towards diagnosis and treatment. There's little or no funding that goes towards demand generation, whereas this is the end of the spectrum that we need a lot of support in. And so that makes it very difficult for even the civil society organizations that are doing their best to, catch on the lower hanging fruits of awareness, sensitization, and education. It's very difficult for them. And like I said, that is the end of the spectrum that we have a lot of problems in. All the programs that came in, again, when I was the first lady in Kebbi State, nothing was allocated. We had a cervical cancer screening program, for instance, statewide, very well funded, WHO, CHI, lots of partners, but there was zero funding allocated to the demand generation end of it. So we had to really push for the government to take up that end, because you will have the program, everything is set up there, you have all the cryotherapy, you have the swabs, you have everything, but the women just won't come. So I think that is one thing that we should try and work on some more, having our programs and work plans to include some funding for demand generation. So those were just a few comments I was going through my mind. Thank you.
Thank you, Dr. Zainab.
Assalamualaikum. So my name is Dr. Irfan Kabir. I'm head of Department of Surgery at Peshawar. I just have a brief comment and a question. So we live in a society which has a lot of biases, and there's a lot of stigma related to all cancers and diseases for that matter, whatever cultural factors they may be with that. Um, the stigma with cancer has to be dealt with both in the peripheries as well as in the center. And we have a lot of problems with this big cities where educated people, like I said, maybe literate or not literate, are having their own thoughts on things like vaccinations against HPV virus and so forth. And already there's WhatsApp messages going up and down the country saying, don't do this to your kids and whatever. And the same thing goes with breast cancer. So till that is sorted, the issue of screening and probably is going to take some time. My main question is, in a country like Pakistan, where in the peripheries, your general surgeons are doing breast cancer surgery, where they may or may not really understand the technical aspects and the biological aspects of cancer management. So is there a national strategy to maybe shift from general surgeons like me wanting to do breast surgery to maybe those who are trained in breast cancer and really have the facilities and the equipment available to take this on in the peripheries? Because till the periphery is kind of developed for breast cancer, the cities alone having 1 or 2, 3, 4 cancer centers in the big cities is not going to deal with this problem. So till that is sorted, the stigma is not going to go, because people go to the peripheries, they go to a general surgeon, they make a hodgepodge job of it, and then that suspicion of cancer and doctors not being able to treat the disease grows, and that's fanned by all this. So is there a plan for this at all at a national level?
So till to date, we do not have national cancer policy, or there's no such policy from Pakistan Medical and Dental Council to restrain general surgeons from performing lumpectomies or mastectomies. Obviously, over the last couple of years, there's a lot of voice about it as a breast surgeons. And you know, the CPSP, the College of Physicians and Surgeons Pakistan, which is a sort of a statutory body for training in this country for residential training. And they have developed a breast surgery fellowship program so that people can do that fellowship and they can be trained and they can perform specialized procedures. You can only, you can discuss, you can raise slogans, you can discuss with the policymakers about it. But I foresee that it's going to take some time when general surgeons will stop doing mastectomies or lumpectomies without properly diagnosing patients. Um, but this will take some time. But till to date, we do not have any existing policy in hand which can restrain them from performing these procedures.
We don't have any policy, and we also there are disparities. Like at times we are fantasizing the breast conservation surgeries in different talks, and even general surgeon, they are trying to conserve breasts just to tell the population that yes, I can do this surgery. So and also that, as Dr. Lubna mentioned, that in resource limited countries like ours, where we know that we have limited radiotherapy machines and we are performing breast conservation surgeries. So a surgeon must be thoughtful of all the aspects of the treatment of the breast cancer. As like you people are surgeon, you have your societies. I think you can talk in your meetings to formulate the general policies. So all the surgeons and all other, and obviously with the authorities, where you need breast conservation, where you can avoid unnecessary lumpectomies, where later on patient faces outcomes with bad outcomes due to these unplanned surgeries. So it's up to all the stakeholders to make such policies for the patient care.
Dr. Julie, if she can answer, by but online audience. Only a fraction of females in Pakistan undergo opportunistic mammographic screening. The affording class. This country cannot afford to offer a formal mammographic screening program for females in the target population. The figure would be in millions. We need to develop breast cancer physicians skilled in doing ultrasounds to detect the breast lumps and promote breast self-examination and clinical examination. And they've asked for Dr. Julie's thought on this.
So I think looking at that slide I showed on the WHO recommendations on early detection screening mammography, they made a big case for breast self-awareness and for the primary care community to do breast exams, and that helps teach the woman how to examine her breast. Sticking to evidence, we do not have randomized trials of ultrasound versus not in reducing mortality like we do for mammography. And it would certainly, although a nationwide screening mammography program would cost a lot of money, an ultrasound program would also cost a lot, and we don't have the evidence to back it, even if it costs less. So ultrasound might and likely is better in a young, dense breast. We do know that, and so mammograms aren't as good at finding very early cancers in young, dense breasts. So it's complicated. I can say, I think we have some evidence for promoting breast examination by healthcare professionals and the teaching that goes with it, and encouraging women to have, we call it breast self-awareness, as opposed to you have to do it every month, because we also haven't proven, we had randomized studies of that and did not prove that at least in China, reduced mortality. So I think there are ways that we can get earlier diagnosis without a nationwide screening program. And some of these ideas or suggestions for how we might do that. But more than anything, it sounds like we need to create awareness and education, because even when screening mammography was offered in the neighborhood, people, sounds like, at least in that one pilot we heard about, did not show up. So we need more education, awareness. Come in if you find something, let's check it out. And it might be, I don't know your primary care community like you do, but it might be that's where we need to have some education as well. Who are the healthcare providers that are interacting with the women at that early stage that can educate them and teach them about what your own breasts feel like? And if we want to get men involved, we can teach them what, and what you do when you find a breast lump.
Take the last question of the session because we are short of time now.
I'm Dr. Farzan Ali, Fellow Medical Oncology, Shaukat Khanum, Lahore. Excellent talks. My question is to Dr. Lubna. What were the most common challenges you have faced during the breast cancer screening programs in the Gilgit-Baltistan?
You're talking about Karachi or countrywide?
Countrywide, and especially you have done in GB.
Okay, so basically, you know, when we have been to Gilgit-Baltistan, we found the acceptance rates were high in that population somehow. Because I would say, you know, it's a community-based sort of a program going on there, and they were trained, they were taught before about it, that why this is important. The acceptance rates are very high when we went to GB for the sake of screening. In terms of breast examination, how to do it, even their paramedics, they really want to learn. uh, the females who were like residing in the rural areas of Gilgit-Baltistan, they really want to learn how to perform a clinical breast examination or how to do it regular on a regular basis. And you will be surprised that we actually have patients or maybe asymptomatic individuals who were connected through Zoom consultations to us afterward when they discovered something in somebody's breast because they learned how to do a breast examination. So I would say the results are very consistent over there as compared to other part of the Pakistan. If I talk about Karachi, there's a lot of, you know, there's a lot of friction there with terms of screening programs. Very few hospitals are providing screening modalities. And still, I agree with Dr. Amna about it, that somehow, as Zainab said, this is a patriarchal society. Most of the females are dependent on male partners to support their finances or maybe to take them to the hospital for that screening purpose. And that's why they're neglected. They don't want to give that much attention to it. So acceptance rate in our city is much lower.
Assalamualaikum. My name is Shumaila Khadak. We often discuss about breast cancer awareness sessions, but we don't really discuss about other types of cancers. Like there is no public awareness usually about all the other types like lung cancer, colon cancer, etc. My mother was diagnosed with colon cancer last stage. She passed on later on. One of my question is this: why most of the hospitals in Pakistan don't treat the patients in last stage? Number one. Number two, why there is no public awareness session about early symptoms of cancer? Because most of us are diagnosed at the last stage. I do mammographies at Doctor Hospital Lahore, and most of the patients who come over there, they are diagnosed in the last stage. First, they have fear of telling others about their symptoms. They are ashamed about it. And even if they are diagnosed with it, they don't discuss with their families. They even tell us, don't discuss our reports with our family member, just tell us about the report, etc. My main question is this: why there is no public awareness about other types of cancer, just like breast cancer? Number two, why most of the hospitals don't treat patient on the last stage? And number three, if a patient recover from cancer, for how long we should continue the low dose maintenance chemotherapies? Like my mother was recovered from last stage. And then after 3 months, although we continued the low dose maintenance chemotherapies, but after 3 months, there was reoccurrence. And within 5 months, she passed away. So for how long we should continue it? Thank you.
So oncologist can answer this question, the water therapy.
Okay. Yeah, your question is quite valid that why don't we have awareness sessions for other cancers? Actually, it's quite a blessing that we have awareness sessions even for the breast cancer. We are limited in our resources, and why we do put so much emphasis on breast cancer awareness, as you just saw in our insightful talks, the burden of breast cancer in our country and the ages of the patient who are encountering this disease. Talking about the other cancers, though, they are also as important as breast cancer.
Definitely.
But their incidence as compared to breast cancer are low. We do talk about those cancers at cancer day, and when their specific days are there, but obviously they are not propagated. These awareness sessions are not propagated as the breast awareness sessions are propagated, because a major chunk of the cancer incidence lies in the breast sessions. Your second question is why all centers don't take last stage cancers. There are always limitation of human resource, other other logistics, but it's not the way that if you are going to a cancer center at last stage, you are denied of treatment. Although obviously your mother got treated at some center, it depends. It's not as per the wishes of the family which center they want to choose. It's the limitations of the centers, which center is taking at what stage and not at other stage. Obviously, they are bound to provide comprehensive care to the patient. So if they can't accommodate, they always refer patients to other center who can accommodate. So if a patient is coming, although we have limited resources, we have limited oncologists dealing with these cancer, still patients are not refused because stage 4 or end stage. They, yes, there's at times a patient is not in a condition to take treatment. They're asked, the families are counseled that at this stage, certain therapies cannot be offered to these patients. And what was your third question? Sorry, if
For how long we should continue the low dose maintenance chemotherapies?
Look, it's debatable things, and I think with this session, it's not related, but it again depends upon the cancer type, patient situation, the resources we have. So I think this addresses your question.
Thank you.
My name is Dr. Hamad. I'm a medical officer in surgical oncology, Shaukat, Peshawar. And it was a good talk, a lot of talk about raising awareness and the stigmas that we have in our society, but especially the stigmas among our general surgeons when it comes to breast surgery is also there, because sadly, they don't take it as seriously, or they don't show interest further in breast surgery. So you have, as Dr. Irfan Kabir said, you have a lot of general surgeons in the rural areas doing a hotspot job of it. So while, yes, breast conservative surgery and radioadjuvant therapy is the way to go forward, but in our setting, you have a lot of breast cancer patients going to general surgeons. So do you think that, is there a gap in our training where general surgeons are not having rotations in specific breast surgery institutes where they can at least get the idea of how to do a mastectomy, so that at least the patients that are going to the rural areas, they don't end up with positive margins? Thank you.
So I agree. Actually, when we talk about training program, in entire Pakistan, as I said, CPSP is a controlling body for the entire training programs of surgery and medicine and oncology or anything. So, it just need to be revived again. If we talk about the general surgery training program, yes, they can design a strategy where we can send their residents to a program where they have a specialized breast units. So at least in a 3 month or a 6 month rotation period, a surgeon can learn at least basics about it, how to perform a mastectomy or how to diagnose the case properly, rather than doing a first-hand lumpectomies or a mastectomy without performing a biopsy, because this is not uncommon in our part of the world that people are performing mastectomy for a huge fibroadenoma also. They think this is a cancer and they perform a mastectomy, and the final histopath is coming like a fibroadenoma. So there's a need for redesigning the entire residency program at CPSP level and at PMDC level. I agree.
Thank you.
There are two questions from online audience again. One is how can national initiative should be taken to bust myths and push government for national registry initiatives. And second is, I guess, from Dr. Lubna. She's the better person to answer. how can we can bridge the gap of availability of facilities for sentinel biopsies, breast conservations, or diagnostic facilities to the peripheral area of Pakistan.
So We Can, which is our Women's Empowerment Cancer Advocacy Network, really was a regional effort. And when I took my job at ASCO 4.5 years ago, because it was conducted out of the University of Washington, I couldn't formally continue the work, although by that point, the advocates in Eastern Europe and Central Asia and East and Southern Africa were equipped to continue to do the work. I think to empower groups, and Pakistan is a big country and you've got several hubs, and to help promote, support patient advocates in your different cities, and then bring them together so they can learn from each other. And maybe, and I don't know which surrounding countries you might best identify with. But if you can, with where?
Collaborate we can.
Well, right. So with the region, if you identify a strong advocacy group in another country even, and you can learn from them, or I suspect, there are groups in the US and in Europe who would be happy to do some consultation if you pull together some patient advocates who want to grow their advocates toolkit by UICC, the Union for National Cancer Control, that Dr. Zainab is the president-elect of. And so I think it was a pharmacist asking the question. I think we can all identify women who are willing to speak out and advocate and support each other, and then connect them.
So the next question was about sentinel node biopsy and breast conservation and diagnostic facilities. Yes, I do understand in far-flung areas of KPK, or maybe in Sindh, or maybe in Punjab, or definitely in Balochistan, we do not have facilities for the sentinel node biopsy if we talk about the gamma probe and all the infrastructure. But I think we can learn how to perform a sentinel node biopsy in the cost restraint settings with the help of dye, the methylene blue you can use. It just need that whoever has a willing to perform this procedure, they can come and do selectives or electives at breast units all over the Pakistan. Whether you talk about Lahore, you talk about Karachi, we have surgeons who are performing it in specialized centers. People can learn. We are open to train them. That's not an issue. And so is true for breast conservation and for the other diagnostic things. The other question she asked about centralized tumor board. Uh, in Karachi, we have our own setting of a city tumor board where people are bringing their cases to the city tumor board. And it's on every Sunday. You can join to that city tumor board through Zoom link and can present cases.
Okay, with this, we come to the end of our session. And I thank you all for your so profound engagement, all the audience, our speakers who presented such insightful and informative talks. And we had a very good question answer session. We all know that in Pakistan, despite we don't have a national registry, but the stats we see from certain hospitals, local registries, are quite alarming in regards of the breast cancer. And we, as a healthcare professional, we know the actual situation, what's going on in our country. People are presenting with late stages, and we have to deal with those cases. We need comprehensive policies from at our national level with the collaboration of all the stakeholders. But as a healthcare professional, I say that we need to uh, uh, to educate our public. Wherever we come in contact, we have a chance to educate our public regarding awareness for the early symptoms and signs of the breast cancer, where we can be of help regarding creating awareness of screening and early detection of breast cancer. We should play our role. Thank you all of you, and all of our speakers. Have a good day.
Thank you, Dr. Zainab, as well, for joining.